This is a wiener dog. Wiener dog, disappear. Because we're not talking about that today. Welcome to Reproductive Disorders. Okay, I gotta make a little disclaimer before we do start on reproductive disorders. I don't really know this stuff all that well. Don't tell anybody. Infertility is defined as an inability to conceive after 1 year of giddy up, papa, giddy up, papa, Did you know that infertility workup includes both the man and the woman? And here are listed various causes that may be evaluated for. On both sides of this slide is listed the idea of the biological clock. And the most important thing I could probably say here is that a lot of people don't even know that men have a biological clock. Did you know that as men age, the number of mutations in sperm goes up considerably with each decade of life? So, the next time you see a younger woman with an older celebrity guy and they suddenly have a kid, it's probably going to look like me. Primary amenorrhea means no menses, and primary means we can identify that it's right there within the root architecture of what should produce normal menses. Turner syndrome is a genetic condition whereby a woman only has one rather than two X chromosomes. Maybe the woman has a specific anatomic abnormality that prevent menses. Or perhaps the communication between the hypothalamus, pituitary, and ovaries and uterus just ain't working the way it should. Primary amenorrhea. Now, is primary amenorrhea the only menstrual disorder? No! Am I going to talk about all the other ones? No! I'm just not an expert on these. Okay, cut me some slack. There are other types of menstrual disorders. They are not a focus for this class, but thankfully there is within the curriculum a maternal newborn class that often does cover a lot of women's health. I've often found endometriosis to be just a fascinating phenomenon in that endometrial tissue just starts growing where it shouldn't. Isn't that interesting? Some of the thoughts or theories behind why women develop endometriosis have to do with the possibility of retrograde menstruation, which is where the regular menses that would kind of flow outward actually flow up into fallopian tubes. And another idea is that perhaps the endometrial tissue or other tissue within the reproductive tract undergoes some type of phenotypic change. And remember, all of those cells in there have the capacity to be the endometrial lining. So perhaps there are phenotypic alterations whereby other cells are kind of turning on the I want to be an endometrial lining cell. And perhaps that's what's causing it. Ultimately, we don't have a good explanation. Now, fibroids, or uterine leiomyomas, we actually do have a fairly solid explanation with regard to the genetic changes and the different genotypes that produce a common phenotype. Let me say that one more time. A woman can have quite a few different alterations to the genes within the myometrium, the muscle wall of the uterus. And the same thing is the output, the clinical presentation, which is this benign mass, this leiomyoma, better known as a fibroid. Everybody asks the same question, so before we finish talking about fibroids, I will say that women who develop fibroids are not considered to be at any greater risk for development of uterine leiomyosarcoma, which is uterine muscle cancer. Ladies, did you know that oftentimes as you get older, have children, whatever the case may be, some of the strength in the pelvic floor muscles can get weaker. And in so doing, can allow some of those pelvic organs to kind of shift in place a little bit. Uterine prolapse is one of those scenarios where the uterus, just like the picture showing, kind of goes south. But the uterus isn't the only thing that can go south. The bladder can start pushing in on stuff. The rectum can start pushing in on stuff. The small bowel can start pushing in on stuff, which is called enterocele. So here you've got cystoceles, rectoceles, and enteroceles, and these are usually caused by weaknesses to supporting musculature and whatnot within the pelvis. And you just get kind of different things, drifting around. Ovarian or testicular torsion are the same thing. And just talking about them makes me just want to cringe because it's taking your Netherlands stuff, just twisting it. Okay, stop the show. Polycystic ovarian syndrome is yet another genetic-based syndrome, but it's not necessarily an inherited mutation. It's people that have kind of the right combination of susceptibility genes, normal genes or variants of those genes. And then when those susceptibility genes are in the proper environment, and maybe that environment is nutritional, maybe that environment is pro-inflammatory, but in the proper environment, these two things kind of coalesce and cause polycystic ovarian syndrome. And actually, that idea of the right normal gene variants plus the right environment equaling disease is an equation that's common in a lot of pathologies. The clinical presentation for PCOS is probably what you'd expect. If you're not familiar with the term hirsutism, that means the development of hair in people who would not normally have hair in places where they would not normally show growth of hair. There are many subcategories of fibroadenomas. So we're just kind of talking about it here in kind of a very broad overview. Fibrocystic breast really isn't a disease as much as it is probably just like PCOS, the right genetic variants within the right environment produces cysts within the breast. This is a very, very common thing, and roughly 50% of breast biopsies that are done because of an irregularity on mammography show a fibroadenoma, a benign growth. Another important thing to counsel your patients on, because a lot of them will get this diagnosis and then be scared that they're going to go on to develop breast cancer. Unless there's other compelling risk factors, fibroadenomas are not known to increase risk for breast cancer later on. We're going to play a short movie to kind of reiterate cervical cancer and the genetic changes that occur when the HPV virus integrates into the host cell's genome. I do this because it's kind of a different way of visualizing it. In the slide set, I'll also have from Immunopedia really detailed slides and explanations explaining how this process occurs, for those of you that like greater detail.
The DNA from the HPV virus contains 9 different genes. Early genes are designated as E, and late genes are designated as L. When the linearized HPV DNA integrates into the host DNA of the infected cell, some HPV genes are lost. Most importantly, The HPV gene E2 is deleted, which shuts off the E6, E7 oncogenes. The tumor suppressor genes P53 and RB exist as proteins in the cytoplasm. When the E6, E7 mRNA is made following the deletion of E2, they are made into proteins which bind to P53 and RB and inactivate their tumor suppressor functions. Cellular transformation ensues, leading in many cases to cervical cancer.
All these terms here are guy terms. I'm just going to let you kind of read through them because if I talk about them, then I usually kind of take on weird posturing. I don't want to do that in the movie, right? For once, I'm going to talk about cancer and not give you an oncogene or tumor suppressor gene, but they're definitely in the equation here. I just want to say a couple things about testicular cancer that make it unique from other cancers. Testicular cancer falls under the category of a germ cell tumor. Ovarian cancers in young women also fall into this category as well. These cancers are typically fast growing, they're typically aggressive, but, and this is a big but,
I like big butts and I cannot lie.
They're also very responsive to chemotherapy. Their cure rate is very high, and even patients who have metastatic disease can often still get a long-term cure. Okay, now the big topic for Reproductive Week, breast cancer. Unfortunately, many women will be diagnosed with breast cancer at some point in their life. It's so common that population-wide screening is in place. Nations don't pay for population-wide screening unless a cancer has a high enough incidence that it warrants doing so. What puts a woman at risk for breast cancer? Family history probably makes sense. A person's age probably makes sense too, because if cancer is a result of genetic mutations, the older we get, the more mutations we have. But age actually goes a little bit deeper when you're thinking of breast cancer risk, because also under the age category is calculating the age at menarche and the age at menopause. Women who undergo menarche at younger ages and women who undergo menopause at later ages have more exposure to kind of their monthly cycles, and that's known to put a woman at higher risk for the development of breast cancer. Interestingly enough, never having children also raises breast cancer risk, and the protective effect of childbearing is something that has been debated in breast cancer risk literature for a long time. The BRCA1 and BRCA2 genes have been in the news over and over again, and we're going to talk about those in 1 minute. A woman's ethnicity can put her at a higher or lower risk of breast cancer. Women of European descent are considered to be at the highest risk for breast cancer development. Body mass, obesity, and physical inactivity are risk factors that kind of go together, and they really center around how excess adipose tissue in the body releases the enzyme aromatase, which ends up increasing estrogen levels within a woman's body. Alcohol intake does not have at least a causative role. However, it's possible that women who drink alcohol are also sedentary and perhaps obese. Leishmania is a germline mutation to the tumor suppressor gene P53, and breast cancer is one of many, many, many cancers that people with Leishmania can develop. I just want to have a short conversation with regard to the BRCA1 and BRCA2 genes. They're very popular genes. I think when Angelina Jolie came out a couple of years ago with regard to her BRCA1 mutations, she really popularized these genes in kind of the lay press and in popular culture. The first thing I'll say is BRCA1 and BRCA2 are tumor suppressor genes that we all have. And they are in the epithelial lining of the breast, but that's not the only place that these genes and their proteins are found. Both genes are tumor suppressor genes, and we already know in this class that if a woman inherits a mutation to a tumor suppressor gene, that definitely puts her at a significantly higher risk for the development of a cancer later on. Germline mutations typically yield a cancer at a younger than normal age, and oftentimes multiple cancers. One other interesting thing to note about BRCA mutations is their relative lifetime risk. 40 to 80% lifetime risk. I want you to look at that another way. Think about it this way. So a woman with a BRCA1 or BRCA2 germline mutation has a 20 to 60% chance of never getting cancer in her life. Please take some time to think about that because it highlights what we don't know yet about a very big gene. For example, the BRCA1 gene is somewhere around 70,000 base pairs long. A woman who has her mutation at base pair 10,000 yields a different protein than a woman who has her mutation at base pair 60,000. We're getting to the point where we can subdivide BRCA mutations by risk and risk stratify them, but we're not there yet. So breast cancer can be subdivided by which part of the epithelium sustains the genetic mutations. Is it in the duct or is it in the lobule? Vast majority of breast cancers are ductal carcinomas. A good portion of breast cancers are diagnosed at the DCIS stage, ductal carcinoma in situ. And what that means is there's an invasive cancer there in the ductal epithelium, but it hasn't gone anywhere yet. It hasn't broken through the basement membrane. It hasn't invaded anywhere. Any in situ cancer is considered stage 0. I'll also add that breast cancer is the only cancer where 20% of the time you diagnose it at stage 0, which intuitively you could probably guess means very high cure rates. Now, beyond stage 0, you have a true ductal carcinoma that has shown some degree of local invasiveness. So this would be stages 1, 2, 3, and then at stage 4, you have breast cancer that has metastasized to other parts of the body. So what genes get turned on or sustain mutations such that a breast ductal carcinoma can grow? There are two common ones. The first pathway is an amplification, or you could think of it as an overexpression of the gene that creates the receptor protein on the outside of the cell for female hormones. And one of the molecules it uses as a ligand is estrogen. Estrogen comes in, binds to that receptor protein, and it sends a cell signaling message right to the nucleus that says, grow and divide, grow and divide. If you hear a woman has a breast cancer that is ER/PR positive, it means that her breast cancer cells overexpress these protein receptors on the outside of them, and therefore they're able to use estrogen as fuel. What's the good news? If a woman takes estrogen blocking therapy, she can see a marked reduction in the size of the tumor. The second genetic abnormality is another amplification of a normal gene called human epidermal growth factor receptor 2 that most clinicians just call HER2. In this genetic abnormality, this gene gets overcopied, overtranslated, and many copies of its protein are, just like the estrogen receptor, put to the cell membrane. Now, the HER2 protein doesn't bind to estrogen like the estrogen receptor protein. The HER2 protein on the cell membrane uses growth factor as its ligand. But if there's way more of it than normal on the outside of the breast cancer cell, that means all the more stimulation. And when growth factor binds to that cell membrane protein, that protein sends that cell signal right down to the nucleus to again say, grow and divide, grow and divide. What's the good news? We have had anti-HER2 medicines out for women since 1997.
Herceptin, a multimodal approach targeting HER2-positive breast cancer. For some women, effective treatment of breast cancer can start deep at the root of the disease. Some of the most aggressive breast cancers are driven by a transmembrane receptor protein known as HER2, a member of the HER family of receptor tyrosine kinases. Roughly 20,000 HER2 receptors are typically expressed on the surface of healthy breast cells. In approximately 25% of primary breast cancers, the HER2 protein is overexpressed, resulting in tumor cells with as many as 2 million receptors present on the surface of each cell. These cancers are called HER2 positive. The effect of HER2 overexpression is a tremendous increase in receptor-mediated intracellular signaling, directing the cell to proliferate uncontrollably. For this reason, HER2-driven disease results in an aggressive form of breast cancer, which, if left untreated, can progress rapidly. Herceptin is a monoclonal antibody specifically designed to target the HER2 receptor. With an extended half-life that allows for constant exposure to tumor cells, based on preclinical studies, Herceptin delivers continuous inhibition of HER2 activity by working on both the extracellular and intracellular domains of the receptor. Herceptin is the only approved therapy designed to bind to HER2-positive tumor cells extracellularly and flag them for destruction by the immune system. In addition, bound Herceptin prevents HER2 receptor activity by blocking intracellular HER2 signaling and ultimately inhibiting cell proliferation.
I have used this chart for years for students because it doesn't matter where you work. I can guarantee women are going to come to you and go, I got a lump here. Well, I don't know, it's a little cyst here or a little lump here. And you're going to have to respond in some capacity. This chart is a useful tool to think about when you're responding to women who come into your primary care clinic and say, hey, I discovered a lump here. And what this chart is meant to show you is where breast cancer occurs most of the time, as well as where it least commonly occurs. We won't get into specific chemotherapies for breast cancer, but the idea of triple negative disease versus triple positive disease is such a common term clinically that I want to introduce you to it. If a woman has a triple positive breast cancer, the way you'll hear clinicians say that is it's an ER/PR positive breast cancer and a HER2 positive cancer. So there's kind of three protein receptors that are overexpressed and are fueling. They are oncogenic proteins, they're fueling the growth of the cancer. Contrast that with what's called triple negative disease, common clinical term in the breast cancer world. Triple negative breast cancer is a breast cancer that does not overexpress female hormone proteins, so those two are knocked out, and doesn't overexpress the HER2 protein as well. The reason triple negative breast cancer is a term that's commonly used in breast cancer circles is because what happens is those women with those breast cancers don't have the most favorable therapeutics to use. They're kind of stuck with old-fashioned, old-school chemotherapy.